I came up with a new app. I was getting depressed today. And you know, antidepressants take too long. So I was thinking electroconvulsive therapy is much quicker. So if we could really charge these cell phones up and get the right app, you know, just a little application, and everything would seem bright and cheery. Could sell. So in all seriousness, it's been a really long day and really great stuff. I'm sure everybody's tired. And some of the things in my slide deck, there's a lot of slides, I'll warn you, have been covered to some extent. So I'm going to take the gift of time, mention that, you know, I'm a practicing physician. I've been in the game doing home-based care since 1984. And I've actually had patients that I've been seeing for almost that long. Last 2 sessions of house calls, I took medical students with me, usually do. Saw a lady who had known me when she was running a small private adult home, and she died during the house call in front of 2 medical students and me, with some CPR involved and some 8 EMTs who sort of brushed us aside dismissively. I turned off her television and her air conditioning as we left her house. I figured it was probably the last time. I looked around at the pictures. I showed the pictures of her family to the medical students. Then we went to another house of a lady who has been my patient for more than 25 years. She's 87, and she's now really home limited from a complicated medical problem. I took care of her in 2 nursing homes, around in 12, in my office practice and in the hospital. And what I'm trying to convey to you is a sense of an understanding of the continuum of care and the realities of this world that you get by being there. And I think I have that, and Robin has it. Others in this room likewise have it. I'll mention the last 2 house calls briefly. The guy that we saw at home who's tetraplegic and 53 now, has been my patient for 20 years, mostly in the prone position because that's how he maneuvers best with his limited use of his hands, has developed pressure ulcers on his elbows, has had multiple hospitalizations with urinary tract infections in a nursing home. Once said he's never going back. They give him pressure ulcers. Very dependent on medical technology, specifically his bed and his wheelchair. The personal care part of this, he runs a consumer-directed care model for himself. He says the 3 women who've been assigned to co-manage with him are not very competent, so he's taught them how. And he's trained how many different individuals to be his aides, how to do proper quadriplegic care, which is not easy. Minority individual shot in the neck by accident at age 16 on Coney Island while walking with his sisters. Went and got a master's degree, became a teacher. Taught the sister of the woman who's now his personal care directed aide, who lives in the front room of the house where he is. She smokes a lot. She has a baby. She has a husband. It's not a very pretty situation, but he has been homeless, so it's a lot better situation than has been the case for him in the past in many circumstances. He has a laptop. He's waiting for his internet service provider to be reconnected, and I'm going to try to get him back into the realm of teaching. He's a very effective teacher. He trained some of his aides who are actually at night, how should I say, striptease club employees. He said that was a very interesting period for him, and that they actually did a pretty good job. You know, one lady came over and then he trained several others and they became quite effective. My point in telling you these anecdotes is that this is a very heterogeneous world in which we work that has a whole array, a matrix of components to it, hard to measure in a reliable, consistent manner so that you can say structure, process, outcome, and be able to categorize it in a way that's going to be acceptable on a federal health policy level. So now we're going to go with slides. So we do have to have some way of defining the population. We've talked several times about that. I'm going to tell you one of the good things about giving a talk is you say up front what is going to be the most important thing to remember. So the most important thing I'm going to tell you is that for the really complicated 6 subset of these patients, the ones, the Tom Eads ones, at 5% cost 50%, they don't fit inside our usual care systems. We've been redesigning the silos 27 different times, trying to find a way to make them fit. They don't fit. We need to carve them out, put them in a different model, pay for it differently, measure it differently, and take good care of these people, including a medical component. Much left out. I'm not wanting to advocate too much for the thing that I do, but I've got to tell you that for a large part of the problem that we have, the medical component has been left out for too long. There are lots of other issues as well described by others. At the end, value, quality, cost. We have to be able to measure what we're doing. We've talked about it. We'll talk a little bit more as I go along. And we have to align the funding and the care models so that we are all working in the same direction. That's been said a million times. And I'll finish up trying to describe a couple of them, including the independence at home model, as one way. So this matrix is something I showed up here in 2009 on the day that independence at home was accepted into the Senate Finance Committee bill. And one of my band of renegades, Tom Eads and Bruce Kanosian and Connie Rao and George Tyler, wherever he is, and someone else, Jim Piles, who are all here in the room, the band of renegades, worked really hard to create. So I was showing this slide about the time that Eric DeYoung put his thumb up and said we'd been approved to be included in that bill. The point here is that these are subtypes, I think, subtypes in my mind anyway, of patients. This is probably not pointing very well. Subtypes of patients who have somewhat different types of care needs. And I think of them as people who could be managed a little bit compartmentalized within inside the home care space. I spend all of my time down here at the bottom. These are the people that use most of the money. This is the demographics. This is the population size in general terms, and it's been spoken to several times. And these slides will stay behind, so I'm not going to spend a lot of time on that. I am going to say that it needs to be a social and medical matrix combined. You can't do this without a good social support system. We've talked a bit about that this morning, but you also can't do it very well without an integrated medical component. These people, for the most part, not always, but often are sick, and they need to have medical care, which is continuous, attached to the rest of their care design, or you end up with people that are going in and out of the hospital, which is not good for them. This is takes after, I think, one of the slides that Bruce Left showed you at the beginning. The medical care piece is small. These other pieces are much bigger and often more important, and we all have to be put together. This is a reminder that the top 5% use most of the resources, and say top 10% use 70%, top 5% use 50%. We could, go on and on. But it is really, if we want to be smart about it, concentrate on those people, and we can make a lot of a difference in a quick hurry. So, I went too fast. Usual care. We've talked a lot today about usual care. So Medicare Part A home health, and this is where I'm going to be taking you through models. Medicare Part A home health we've covered already, so I don't have to say much about it. And this is Medicaid personal care, basically, because there's not much else outside of Medicaid personal care unless you're Bill Gates. And here are the problems on the right. So circumstance on the left, problems on the right in color. Discontinuous, skilled only, intermittent, really a weak medical model for the most part, slow in response to needs. It's slow. There's a lag time. You have like 12 hours to get these problems fixed. It takes 2 days for the nurse to assess the problem or to hear from the aide that there's a problem and go assess the patient and find the doctor and get communication and get an action plan in place. By then, it's too late, and the patient goes to the emergency room. The kind of inconsistent and variable ADL support. The aides sometimes show up. They become like members of the family half the time. They are fantastic, and half the time, you really could do just as well without them. And the payment is in silos. How many of you all were part of the OBQI demonstration back in the Pete Shaughnessy days? Let's see how many. So how many of you guys think that was pretty good? Anybody think it wasn't good? No, it was pretty good, right? So those who weren't familiar with that, at the beginning of Oasis, there was this design that if you took agencies who were highly motivated to do better care and you gave them data in terms of their risk-adjusted performance, just data and training on how to do performance improvement guided care, you asked them to fix one clinical problem and keep the patients out of the hospital. Look what happened. The hospitalizations went down by 25% in the span of 3 years. It really can be done. It was done with a really large number of patients effectively. The problem, of course, is that we didn't take that and make it the usual model. It became just a moment in time, a flash in the pan. Could have been pretty good, but it hasn't really been translated into practice. So now we're going to move on and talk about some newer things that are now operational or coming operational. These listed, and happily, some of them have been described to you, so I don't have to. Just mention a few things about them as we go. Bruce Leff, co-chair of this program today, did a randomized controlled clinical trial. You familiar with Hospital at Home? Somewhat. So just to remind you, this was a randomized controlled clinical trial, small but robust in terms of its design. Took people who were definitely determined to be eligible for being an inpatient and took them right straight to home and implemented a care program at home, which was equivalent to hospital level care. Saved money and fewer complications. Patients were happier, less delirium, other complications avoided, less functional impairment. It was a successful model that saved quite a bit of money. It has not, unfortunately, been replicated or funded to be developed and widely disseminated. There are some great examples, though, of where it has been and works quite effectively. This is a new model, part of the puzzle. So Mary Naylor's transitional care, familiar to many of you. A randomized controlled clinical trial. That's really good evidence, right? For those of you who are health services researchers, really good evidence. And Mary's model, for those not in detail familiar, involved nurse practitioners who were really seasoned veterans of this kind of care, going to people's hospital rooms, learning about them, and then following them at home for about a month, making perhaps 4 home visits over that span of time on average, lots of phone calls, and essentially managing their care as the medical care providers to translate the care plan through, and then handing them back to their office-based physicians. Cut their costs in half, 50% savings, so a very intensive model for a very selected target population, not just any patient, very selected, and quite effective. Some of the problems, though, less easily scaled. People say, well, we really need Mary Naylor and her crew in order to make this work, which, you know, there aren't that many of Mary Naylor and her crew. I'm going to come back to this point because I don't want you to lose track of the sort of the false idea that this can't be scaled. It's just that it hasn't been scaled. It hasn't really been funded appropriately. There's a question of who gets the savings. So the beneficiary economically is the Medicare program, right? And then there is one other problem with Mary's model, which is what we've been doing in Richmond since we implemented Mary's model since 2000. We've been running a Mary model transitional care program for 14 years. We found over time that most of these patients now are not able to transition back. So we say at the end of 4 or 5 weeks, we say, well, toodaloo, except that, you know, you have a person who's homebound and can't go to clinic. And how do you feel about saying toodaloo? They really need the house calls program. So we're moving them into our house calls program. That's a limitation of a new silo, a transitional care silo that we're starting to create. And Eric Coleman has been very effective in helping us understand this problem of care transitions, developed a much less expensive, less intensive model, tested on probably a slightly less thick group of patients that was also very effective. It involved empowerment of the patient. It involved a lighter clinical touch. It involved transformation of the healthcare system in terms of communication, so the patient's record went with them. Saved a lot less money. Not sure about who's going to pay for it. Certainly more easily scaled in today's world than Mary Naylor's model. The community-based care transitions program that was mentioned just a little while ago is interesting and very different. Section 3026, very different kind of idea, right? So this one, Medicare, $500 million, paying a community-based organization to manage patients during a post-hospital care transition. The community-based organization working with the hospital and working with people in the community to become more knowledgeable about how to maintain patients and support them during that turbulent period of time. But again, only for a turbulent period of time and not necessarily longitudinal. The promise of this for me is that it starts to reorient people's thinking in the community and involve a lot more people in the process of improving healthcare at the community level. How many familiar with the GRACE model? Steve Council, so a few. GRACE is another randomized controlled clinical trial that showed a considerable improvement in clinical care process. They took patients, sent them home with nurse practitioners going quarterly, reporting back to clinic-based geriatricians for 3 years, providing recommendations to primary care, half of which were implemented. And in the second year, an intentional evaluation of cost showed that there was about a 30% reduction in overall cost related to reducing hospitalization and emergency room use, even though this was not an urgent care response model or a longitudinal primary care model. It proved to be fairly effective once the patients and these nurse practitioners had gotten to know each other for a while and in a selected, targeted, high-cost population. Again, you have the problem of who's going to pay for this. We heard earlier at the beginning of this presentations today about PACE. Everybody familiar with PACE? More or less, right? Everybody's nodding their head. So became a national benefit in 1997, one of the few positive features of the BUBBA, if you will. Those of you familiar. 2,316 recommendations or implementation policies in that bill. This was one of the good ones. But the only problem with it is that it requires people to give up their Medicare and their Medicaid and to go into these very structured programs that have a very large overhead. Tremendous cost shifting, so the costs go from hospital to the PACE center, but the PACE center is pretty expensive. Not sure if it actually saves money, but it certainly removes the cost burden from the government by accepting full risk. A very nice model. There are about 30,000 some patients now in PACE around the country. There are about 120 or 130 active PACE centers, which is not bad, but it's been since 1997, so probably not penicillin. Tom has already told you about the VA home-based primary care. I remember sitting trying to convince Tom to become president of the American Academy of Home Care Medicine. We were sitting on a grassy knoll outside a hotel in Washington at the time, and he acquiesced and eventually chose to accept that job. I'm not going to say anything more about HBPC, except that we got how many patients in HBPC, Tom? 34,000 patients, okay? It's not a randomized controlled clinical trial, and it is the VA, which has a lot of control over what happens, but 34,000 patients, and the costs are considerably reduced. Okay, so George Toller is here. George, and you there? There's George. So Tom has already told you about George's paper, which again was a study of the home-based primary care model with a team wrapped around. So George has done great work. He's gone out to the state of Washington, D.C., and engaged the state of Washington, D.C. to provide him with resources. So he has a social worker, or more than one social worker, and other resources, bringing together the whole community-based team around a house calls model, and selecting very sick patients has saved money. 31% in the most complex, sickest group. Overall, 17%. Not bad. Think about all the things we've tried to do to save money over time. How many things have saved 15, 20% of the healthcare dollar anywhere in the health services research literature? Tell me a couple of things. I defy you. You won't find it. So Independence at Home was designed with this in mind. The collaborators sort of pushing this medical model into the mix, right? So needing the team wrapped around, but incentivizing medical care providers and their team to get involved in longitudinal care of a very sick. This targeting actually identified a very sick group of patients. 10,000 patients, 18 centers around the country, 3-year demonstrations still under evaluation. Gain share payments, hopefully enough to support this team model, the addition of the team model into the care process. Yep. So there's some things that haven't worked. I've got 1 minute and 19 seconds. I'm going to just about make it. So there have been several attempts to do sort of care coordination through a call center or something like that, where there's not much integration with primary care. This model has been tested repeatedly, governmental demonstrations, private sector. It doesn't work. It's been a complete abject failure in terms of anything other than patient satisfaction. And even there, my patients say, this nurse keeps calling me every month and talking to me. I don't really want to talk to her. And why is she calling me? I say, I really don't know. The patient-centered medical home, if you're homebound and traveling by stretcher, is not very patient-centered, honestly, right? Because you've got to come to see me in my office when I say, not necessarily patient-centered. And with all due deference to some really forward-thinking managed care organizations and ACOs, this kind of model that we're talking about, I'm saying carve out, has not, for the most part, been adopted by any of those kind of organizations. They are treating the main of the population and not the sickest subset as their focal point. Well, here's some examples, I hope, of other. I got 6 seconds. All right. I think this group of patients down here, this is sort of a flow diagram you can have for future. If they're not able to come to the clinic, we should take care of them at home. This is my last slide, so we're in good shape. So we got on the left standards of care. No problem convincing anybody that statins are good if your cholesterol's high. Problem is, you got a group of 80 and 90-year-old people. There's also no evidence that it does anything to save lives or improve outcomes, and it is expensive, and they cause muscle aches and altered mental status and so on. And we have no trouble sticking drug-eluting stents into people or putting AICDs in at $50,000 a pop. We've had no trouble, for those who are interested in the idea of expanding a workforce. 1997, there were no hospitalists. Now, you go in a hospital, you're going to see a hospitalist. That's how it is. That's just because they don't pay their way from billing. The hospital is paying for them. So if you're wondering, can we do this? Absolutely. We just have to line up the incentives and say, let's do this. We want a care model that has more aides in the home, trained aides, line up the incentives and pay for it. Right? We had no trouble doing it with hospitalists. I'm going to go back for 1 second, if I can. Oh, I can't. Oh, well. Can I? I can. Last. Nope, next one. Yeah, so, we've got a good deal of evidence now, really direct evidence that's scientifically sound. We know it's right. If you go in people's homes and take care of them, you know that what I'm telling you is right. It's not something that you have to make up. It's time to move on. We've had 30 years talking about this. We need to go and do something about it. That was my last point.